I'm Dr. Ritu Agarwal, and I'm going to present this month Curious Case webinar. That's the August 2025 Curious Case webinar. Typically, the plan for today is that I'm going to show you a few cases, and each of these cases followed by a poll. And you can put your answers in the chat box. And then I'll run you through the cases and some teaching points followed by that. I hope that's okay. If there is anything else, then you can put in the chat box, and I can take it from there. So, going to our first case. This is a 38 years old male with progressive shortness of breath, and the echo showed dilated RA and RV. And I'm going to run through these images. This is a scroll. We are going from top to bottom.
Hi, we need you to share your screen, please.
Uh, um, can you see my screen now?
Yes, thank you.
Can somebody put a message in the chat box and say if they are able to see my screen? Okay, thank you. So this is the first case. So this is the 38 years old male who had progressive shortness of breath, and there is dilated RE and RV on echo. So this is the actual images. We are going from top to bottom. And these are the coronal images. Yeah, so I'll just show the actuals once more, and anybody who can come up with a diagnosis can put that in the chat box, please. So what's the most likely diagnosis? So is it like a PAPVR with a sinus venosus ASG, or it's like a PAPVR, which means a partially anomalous pulmonary venous return without a sinus venosus ASG? Is it a TAPVR or is it a PTA? Anyone? Yeah, so one of you says it's a PAPVR with a sinus venosus ASG, and I guess that's a correct answer. So these are the representative images. So that's the left atrium, left ventricle, right atrium, and the right ventricle. And this is where you see the defect in the interatrial septum. I mean, it's the sinus venosus ASC is a defect in the superior portion of the septum. That's the anomalous venous return, the right superior pulmonary vein, which is draining into the SVC. And then you can see the dilated RA and the RV, which is significantly larger in size as compared to the left atrium. So the final diagnosis was it's a partial anomalous pulmonary venous return with the sinus venosus ASD. The right superior pulmonary vein is draining into the SVC at left atrium, and RARV, and the pulmonary arteries were enlarged. So just while scrolling through these images, these are the that was the right inferior pulmonary vein, and on the left side, that's the left superior, and that's the left inferior pulmonary vein, all of them draining into the left atrium. So the right superior pulmonary vein was anomalous, and it is associated with the sinus venosus ASC, which is causing the shunting and causing the anomalous venous return. So that brings us to a second case. Again, this is a 17 years old male who had progressive shortness of breath and had a dilated RA and a RV on echo. Again, we are going from top to bottom. And these is the coronal images. Scroll from front to back. So this case is a little more difficult than what was the previous one. Um, I'll scroll this. Actually, let me just once more. Yeah, so again, the options remain same. So, what's the diagnosis in this case? I'm sorry, I messed up. Okay, sorry. Yeah, so what's the most likely diagnosis? It is a PAPBR with a sinus venosus ASD, without a sinus venosus ASD. Is it a TAPBR or is it a PDA? So, anyone? Okay, so Ahmed came out with the right answer. It's a PAPVR without a sinus venosus ASD. Now, these are the volume rendered images of this patient, and these actually show the diagnosis pretty well. So, that's a left atrium. These are the left sided superior veins, pulmonary veins, and that is the SVC. And you can see the right sided superior and middle vein, which is draining into the SVC, and the right inferior is draining into a branch artery, which is by through another vessel communicating with the IVC. So that is the labeled image. That's the right superior and the right middle pulmonary vein, which is draining into the SVC. And this right inferior pulmonary vein is actually communicating with the left atrium. But then there is a branch from the right inferior pulmonary vein that is communicating with the intrahepatic IVC. So now I'll show this again on the coronal images. So you can see here this is the right inferior pulmonary vein. This is draining into the left atrium. But then if you trace this vessel curves down and communicates with the another branch which drains into the IVC. Now the point here is that this is not a schemata vein, because the schemata vein will not drain into the left atrium. So the schemata has to be an anomalous communication. So this is a partial anomalous pulmonary venous return, and there is no ASD, unlike the previous case. So this was a learning point for me as well, that the PAPVR might be without sinus venosus ASD, which is less common, but it can happen. And just to show what a schemata looks like, this is another case that I had from my training days in the Cleveland Clinic. So again, this is a scroll going from the top to bottom. And if you look at this vein, instead of draining into the left atrium, it's going down and draining into the IVC. So this branch that's going to the IVC, you can see it on a coronal deformated images. That's the inferior pulmonary vein. I'm sorry, it's the right. It should not be written as a left. So it is a right inferior pulmonary vein, which is draining into the IVC. So that is the schemata vein, where there is no communication with the left atrium, but it is communicating with the systemic vein. So this one had this anomalous arterial branch, and I couldn't find a name for it, but yes, I described the morphology to the referring doctors. So ASG can be classified into two types. One with a direct communication between the left and right atria, which is the ostium primum and the ostium secundum defects. And the other ones are the ones which does not involve the interatrial septum, but they behaves like septal defects, which include the sinus venosus ASD and the unroofed coronary sinus. And these atrial septal defects mostly develop due to an alteration in the interatrial septum, in a developmental alteration in the interatrial septum. And the exact embryology for the sinus venosus defect is controversial, but it is mostly due to lack of separation between the pulmonary veins and the superior vena cava or the right atrium. Now, the sinus venosus ASD are of two types. One is the superior and another is the inferior. So, in the superior, there is a defect which is communicating the right atrium SVC junction with the left atrium. And this is associated with the anomalous PAPVR of the right upper pulmonary vein into the SVC. And in the inferior sinus venosus defect, there is a communication between the right atrium IVC junction with the left atrium. And in this, there is a partial anomalous venous return of the right inferior pulmonary vein into the pericardial segment of the IVC in the right atrium. And these produce a left to right shunt. On a long standing cases, there's a dilated RA-RV and a pulmonary artery enlargement. And over a period of time, they might develop into Eisenmenger pathology due to chronic overload of the right-sided heart chambers and cause permanent pulmonary hypertension. And mostly PA2 systemic blood flow, that is QPQS, will be more than 2.1. This type of patients, when they have a QPQS ratio more than 2.1, then these patients are usually symptomatic and they require surgical intervention. And sometimes these defects are actually picked up on a coronary angiogram, which are done for a totally unrelated cause, and you are not even suspecting them, but you see a dilated RA-RV, and therefore in every cardiac case, it's imperative that you trace your connections and make sure that all the four pulmonary veins are going to the left atrium and all the SVC, IVC are draining into the right atrium, and the coronary sinus are draining into the right atrium. Now, these are actually complex and look at it peripherally, and sometimes echo is not a good modality to see them. And therefore, cardiac CT or a computed CT, cardiac CT is ideally suited for looking at these defects. So, the second case, the QPQS was, I guess it was 2.3 something. Yes, 2.3 or 2.4, something like that. And Ahmed has a question that can it be called Shimata syndrome? So no, as I explained, that for Shimata there should be no communication to the left atrium. So in the second case, the the inferior pulmonary vein was still draining into the left atrium, and therefore it is not exactly a schematic.
So, hi, this is Prachi here. Can you guys hear me? I just want to mention something that one, this case was just fabulous. It's something I've never seen. So, thank you so much for sharing this case where you have a left inferior pulmonary vein draining, I'm sorry, the right inferior pulmonary vein draining into the left atrium, but also having an anomalous connection with the IVC. So it sounds like this in itself is causing a left to right shunt because it's letting the pulmonary or the
Yes,
left
yes.
atrial blood via that conduit into the right side of the heart. So it's kind of working, and that is why probably your QPQS is that high. Otherwise, the only other anomalous vein you have is a right superior vein. So this is truly a fabulous, very interesting case. Thank you for sharing, Dr. Gill.
Yeah, thank you. Okay, should I go with the next case?
Yeah, please.
Okay. Yeah, so the third case is a 35 years old female who had a progressive shortness of breath. Again, she came with dilated ARIA RV on echo. Again, this is the axial stack. We are going from top to bottom. And this is actually a truly a fascinating case. I mean, this is just one of the few such cases I've seen in adult patients. These this diagnosis I've usually found in a young child. Um, I'm actually never seen this in a adult patient. These are the coronal images going from front to back. Okay, the images are pretty classic, and I guess you must have got the diagnosis by now. But I'll just give it another run through the actual stack for those who might be still thinking about it. I don't know why this terminated. Yeah, so the options remain the same. Any takers? What's the most likely diagnosis? It is a PVR with or without sinus stenosis ASD. Is it a TAPVR or it's a PD? Yeah. So that's right. It's a TAPVR. So now these are the representative images. So these are the four pulmonary veins. They all form a vertical vein, and then uh, this drains into the SVC. So when all the systemic and the pulmonary venous blood is entering into the right atrium, and there's nothing going into the left atrium, that's a total anomalous pulmonary venous return. And this, there has to be a communication, a left to right shunt, usually a PFO or a ASD. In this case, it was a ASD, which is required for survival because the blood flow to the left heart depends on this defect. So when we have the TAPVR, we have four subtypes. The supracardiac type, which is the one that I showed you, is the most common type for more than 50% of the cases. And thus the anomalous pulmonary vein terminate at the supracardiac level. They form a vertical vein, as we saw in our case, and then that drains into either the brachiocephalic, SVC, or the zygous vein. And on an X-ray, it gives this snowman or figure of eight or cotton loaf heart appearance. Then type 2 is when the total anomalous pulmonary venous return drains at the cardiac level. This is the image I've took from the internet. It's not my case, and this is seen about in 30% of the cases. In this, the pulmonary venous connection is at the cardiac level and mostly drains into the coronary sinus and then into the right atrium. Um, the third type 3 TAPVC is the infracardiac types when the connection is at the infracardiac level, where the pulmonary veins joins behind the left atrium, forms a common vertical descending vein, and which courses through the diaphragm and enters into the abdomen and joins the portal system. And then it drains into the ductus venosus, hepatic veins, portal vein, or the IVC. And the fourth is a mixed pattern when we is a least common type when we have anomalous connection at two or more levels. So that was about this case. Anybody having any questions here can put in the chat box. I'll just move on to the fourth case. So that's a 75 years old male who had a past history of CAD. He had a history of CKA, CKD, hypertension, hyperlipidemia, alcohol and tobacco use, and he presented with complaints of chest pain, and the diagnoses were non-STEMI. This is the echo image. We can see that. Sorry, I don't know why I cannot play this. Okay, sorry. Yeah. So, what do you think is the most likely diagnosis? It's pretty characteristic. Patient came with a non-STEMI, and is this a pap muscle rupture or septal rupture? Is it intramyocardial dissection or it's a LV pseudoaneurysm? So, anyone who want to answer this? Okay, I'll show you a few more images in case it's still not clear. So this was actually LA and LB. So this is a holodiastolic uh, grade 4 MR, and we did a CT. We can see the L6 is not very well seen, and we see this low density area in the lateral wall. And what we were seeing here, this is actually a ruptured papillary muscle. So that's a near transmural infarct of the lateral wall with rupture of the papillary muscle, which is causing MR. Okay. Now, that's another case. 5 is a 65 years old male who had a heavy history of smoking. He had a left lower chest pain while exercising that resolved on its own without any intervention. Now he had persistent shortness of breath, and that worsened on the day of presentation to the ED. So he had a past history of chest pain that resolved, but now it worsened and he went to the ED. And on ED there was ST elevations in the inferior leaf, and on CAG there was total occlusion of the RCA. So that's a right atrium, that's a left atrium, right ventricle and left ventricle, I'm sorry. And there is this focal defect. So what's the possible diagnosis? It is pap muscle rupture, septal rupture, intramyocardial dissection, or LV pseudoaneurysm. Anyone want to take this? Yeah, I mean, I know from CT and MR I switched to echo, but a little bit basic of echo, I guess all of us should know. So this is the CT images, and you can see this focal defect in the interventricular septum, and this defect is in the mid-infroseptum. That's a mid LV, and it's the mid-infroseptum where we see this large defect, which is compatible with the PDA territory infarct, and the patient had a completely occluded RCA, and the RA and RV are dilated. LV was normal size with near about normal function. So this is a post MI VSD from rupture from septal rupture leading to significant left to right shunting, and this actually possibly had a MI 8 days prior to presentation when he experienced a brief episode of chest pain, which resolves on its own. And then slowly over a period of 8 days, the patient probably had this rupture, and then he decompensated and suddenly present to the ER with worsening of SOB. Okay. So the next case is a 52 years old male who had a history of hypertension and PVD. He complained of chest and back pain. Lab showed increased troponins and BNP. He has this exotic pets and reptiles at home. And since he had a history of chest and a back pain, we wanted to rule out if the patient has aortic dissection. So I'll just play to these images. Unfortunately, I didn't put the coronal images on these, but the aorta can be very well seen. Um, so the question for you is, what's the most likely diagnosis? This aortic dissection. Is there a septal rupture with VSD? Is there an intramyocardial dissection? Or is there a LV pseudoaneurysm? And with these options, I'll play this again once more. Yeah. So anyone who would like to take give an answer, what's the most likely possibility here in the chat box, please? I mean, there's no wrong answer. It's all right. It's okay to take a. Okay, does it seem like aortic dissection? Okay. So the aorta looks okay. There is no aortic dissection, but we do see a lot of other findings, and I've shown it here. There is this filling defects in the right atrial appendage, in the RV, as well as the LV apex. But what was fascinating in this case was this some crescent shaped hypodensity that was at the LV apex. And when we look at the plane scan, we could see these two myocardial layers and a subtle layer of hypodensity between these two myocardial layers. So we went ahead and did an MR for this patient, and even in MR you can see that this is a dark myocardial layer, and then there's an outside myocardial layer, and there is actually this white signal between the myocardial layers, which is showing hyperintense signal on black blood images, which means that it's clot or blood. And because it is going between the myocardial layers, we believe that this is a case of intramyocardial dissection or intramyocardial hemorrhage, which is quite rare. And then on the post contrast images, we can see this ischemia, this infarct in the LAD territory. If you go down, there is a bit of involvement of the LCX as well. It's more marked in the segments becoming near transmural. TI times, this did not seem to pick up any contrast. So it was a thrombus clot, and because of the intramyocardial component, we think that it is a possibility of intramyocardial hemorrhage was given. The patient was put to conservative treatment, but unfortunately died a couple days later, and there was no autopsy or something carried out, so we don't have a final diagnosis. But yes, it was good to see that. So with that, I come to the end of my presentation. I'm really grateful for my mentors at the Cleveland Clinic for training me, and this is a hardworking team that makes everything possible. If anybody has any questions, then I'll take them, or I'll. We are almost at the end of the hour, so I would end the meeting.
Thank you so much. Those were awesome cases.
So I totally second that, Jonathan. Those were really nice cases. I'm sorry I was in and out, so I missed some of the conversation in between. But the cases I saw were exceptional, so wonderful, and thank you very much. A quick question about the last case you showed us, the intramyocardial hemorrhage. Do you
Yes.
think this could, just given the presence of thrombi in so many different locations in the right atrial appendage, right ventricle, left ventricle, do you think it might just be because the infarct seemed like an LAD territory infarct is what it seemed like. So do you think it might all be related to an acute embolic episode to the LAD and maybe I don't know what came first, the thrombus or the infarct, but can we tell that confidently that that's within the myocardium, or do you think that's just a lamellar crescentic clot next to the infarcted myocardium?
Yeah, I guess, I mean, that was the first thought, but then we couldn't explain why it's sort of between the two layers of the myocardium. That was what was curious in this case, that it appears to be between the two layers. So if it is a thrombus, then it would be just on the endocardial surface, and the blood wouldn't be between the two layers of the myocardium. And I honestly, I'm not 100% sure of this case. That's what the literature showed us, and couldn't explain this differential density, differential signal. If we are looking at a thrombus, then why it would have this kind of appearance with two low signal areas and then a bright in between, and the same thing on a SSFP. So that was the reason that a part of it is dissection. Of course, there is a thrombus because we could see it everywhere in the atrium, in the LARV. But a part of the blood is still seeping between the myocardial layers, and possibly that's intramyocardial dissection. I mean, yes, it is a controversial case, but that's what I wanted to show it. That any ideas, something you might have given it something better, or that's what we thought.
Yeah, no, I think it's excellent. Actually, this is very reminiscent of a case I was just reading yesterday. But in that case, what had happened was I had like a couple scans. So one scan was the thrombus was completely filling the apex. On the second one, you kind of saw this differential density, or you can call where it seemed like the blood was seeping in a little bit between the thrombus and the myocardium. And I was wondering, in that particular case, at least, just given the fact that I had two of those scans, I could tell that because of the anticoagulation, there was some interim starting to recanalize. The thrombus was starting to recanalize, and therefore some of it was slow flow, some of it was thrombus, and it was kind of simulating that appearance. But of course, you
Yeah.
don't have the temporal thing, so that's probably the reason to think about that intramyocardial part.
Yeah, I mean, that might have been the possibility. I'm not sure about that. Yes.
Yeah, but your congenital cases were all very amazing, and I learned a lot. Thank you so much. And I also want to tell all the attendees that Dr. Gill is actually, what time is it in India? It's like a totally unearthly hour for her to be presenting this to NASCI members.
Okay, it's a pleasure. I mean, yes, I finished early. I just kept 5 cases. I thought we would have more time for discussion. That was the idea of being taking less cases, and glad I could do it.
Thank you very much. Anybody else has any questions?
Hi, I have a question here. It's Felipe Torres here. Can I ask a question?
Yeah.
So wouldn't we expect in that, in the second image from the left to right there, that intramyocardial hemorrhage wouldn't be dark in T2-weighted images?
I'm not getting the question. The intramyocardial hemorrhage would be.
It would be dark in T2-weighted images.
Yes. Endomyocardial hemorrhage would be dark on T2-weighted images. Yes, absolutely. So SSFP are T2-weighted images.
No, I mean,
That's
in the second image there, which I believe to be.
so that's the black blood image. That's a T1 weighted image.
What
That's
is
a
it?
black blood image which is T1 weighted, and that is the SSFP image which is T2 weighted. And a fresh clot on T2 would be bright.
No, yes, the clot, I understand. Yeah.
Yeah.
Okay, thank you.
Okay. Dr. Prachi, safe to end the meeting now?
Yeah, no, sounds great. Thank you very much. We really appreciate your coming on the call today.
Yes, thank
Thank
you
you so
so much
much.
for presenting.
Thank you.
Yes, it was a pleasure to present. Thank you very much.